Hello friends. Sorry, I'll be just giving a overview on this particular topic, which is a very huge topic, toxidromes in ICU, newer treatment modalities. So this talk had to deliver in Raipur in Criticon Meet on 26th October. So as you see, toxidromes in ICU and newer treatment, you can have a 2 day CME, friends. So this talk to cover in 20 minutes is a challenge. So I've divided these talks into two parts. What are the key toxidromes uh, that we could sort of categorize in ICU, and what are the newer treatment modalities based on the cases that we have dealt? So when we say toxidromes, it is about grouping the toxicology patients based on the symptomology and based on some sort of a basketing these syndromes when they present. So based on either clinical conundrum or based on maybe the ECGs, so on and so forth. So we just look into when we have a patient who is stuporous or delirium or with neurological manifestations, how could we syndromically classify them? So we have one group of drugs which could possibly cause sedation, obtundation, and stroke and make patients unconscious. There are certain distinct group of toxins or drugs or drug overdose which can lead to agitation and delirium. Then there is a third group which can typically cause seizures. Then there are a distinct group of drugs which can cause movement disorders or akathisia. And there are certain drugs which causes encephalopathy. So this I would look at it as toxidromic classification of neurological manifestations of certain toxins. So this is what I can look at it as. So there are drugs that can predominantly act on the brain, and there are drugs that can act on the spinal cord. So there are certain drugs that act by penetrating the blood-brain barrier, and there are certain drugs which act on neuromuscular junctions. I'm sure you would recall most of these drugs. When I say neuromuscular junction, so typically OP compound poisoning, they act on acetylcholinesterase receptors and cause cholinergic symptoms, so on and so forth. And there are certain drugs which causes seizures. They typically cross the blood-brain barrier and lead to problems there. So we'll talk. So this is the sort of a drug classification based on their site of action. So when you look at toxidrome classification, so you have some 4 to 5 broad categories of classifications. The first thing is anticholinergics. So they typically these can cause delirium and hyperactivity and of the patients or agitations in a patient. It could be antihistamines, chlorpheniramine maleate and diphenhydramine. And then you have TCS, which are commonly seen, which amitriptyline. And most of us, we come across not uncommonly TC overdose or antipsychotics like haloperidol or thioridazine and antiemetics like chlorpromazine. They all come under category of anticholinergic toxidromes. Then there are these drugs which are cholinergic, like OP compound. This is commonly seen sort of a toxidrome we see, which predominantly manifests with cholinergic symptoms like malathion, phenethion, and nerve gas like sarin. And then the third group is opioids like heroin, morphine, and codeine, which can make someone stuporous and manifest with neurological manifestations. Then you have sympathomimetic drugs. So these also cause agitation, delirium, like adrenergic drugs, or a drug of abuse like cocaine, amphetamines, and phencyclidine. Then you have xanthines like theophylline and caffeine. Then you have antidepressants, or norepinephrine or reuptake inhibition, like venlafaxine, trazodone, or selegline. Then you have the fourth category, which are sedative and hypnotics, like alcohol, ethyl alcohol, methyl alcohol, or ethylene glycol. Then you have sedative hypnotics like barbiturates, pheno and pentobarbital. Then you have benzodiazepines like lorazepam, diazepam, midazolam, and miscellaneous like gamma hydroxybutyrate and baclofen. So these are the toxidrome classification, which predominantly manifest with neurological symptomology. So this is a toxidrome. So when you look at common manifestations of CNS toxicity of any of these neurotoxins or any of these toxidromes, basically acting on the neurological system. So manifestations will generally be agitation or delirium. Agitation leading to delirium, then they would obviously become little stuporous and then they would slip into a coma. So for all my trainees, so if it is very hard to remember those toxidromic classification of anticholinergics, cholinergics, or antidepressants or sympathomimetics. So you have a mnemonic which can cause seizures, which is called Otis Campbell. So O stands for opioids, T stands for theophylline, TCS, I stands for INH insulin, S stands for salicylates. Campbell, C stands for cocaine, cyanide, or carbon monoxide. A stands for amphetamines, anticholinergics, M metaldehyde. P is, this is important, friends, even carbapenems, we know, can cause seizures. In fact, we see this not uncommonly. And even quinolones like levofloxacin, they lower the seizure threshold. And we do use these drugs fairly commonly. Please bear in mind, so these are the drugs which we use commonly, which can lower the seizure threshold: barbiturates, ethanol, and lead and lithium. So the Otis Campbell is a mnemonic for you to recall the type of drug list that you would want to look at in someone who presents with seizures. So that's about the seizures, drugs causing seizures. Then we have, so why seizures happen? So generally, when there is an imbalance between the glutamate and GABA in the brain, this leads to GTCS. And tricyclic antidepressants cause seizures by acting on the sodium channels. And cyanide leads to cellular hypoxemia, and oxygen consumption in the brain get affected, which leads to seizures. And theophylline and caffeine acts on these receptors, adrenergic receptors, leading to seizures. So these are some of the cellular mechanisms as to why seizures manifest with these sort of toxins. So we finished all the drugs that act on the neurological systems, leading to cholinergic, anticholinergic, adrenergic, and sympathogenic effect. And then we looked at the drugs causing seizures. Then what about encephalopathy? So typically, like paracetamol overdose, which act on the cytokine pre-450, leading to accumulation of N-acetyl paraquinone imine. These to obviously liver dysfunction and encephalopathy. And drugs of abuse like opioids, cocaine, heroin, morphine, they all can cause leukoencephalopathy and increases in the CNS lactate levels. All this can lead to encephalopathy. And in patients with ethanol intoxication, alcohol, there is reduction in thiamine, which leads or which precipitates Wernicke's encephalopathy, which is the common. So these are some of the causes for common encephalopathies or comas, which tends to happen with commonly used sort of a drug toxicity. And there are a list of whole list of drugs which causes a lot of movement disorders, which we call it as akathisia. So if you look at this video, so there is a lot of movement disorders, and it is claimed that many of the drugs that are used in ICU can precipitate and may have a role in causing some of the movement disorders like you see in this video. And there can be these movement disorders broadly classified as dystonias or akathisias. And what are the drugs that cause this? Typically, tricyclic antidepressants, monoamino oxidase inhibitors, and SSRIs or atypical antidepressants. All of these have an ability to cause dystonias and akathisia. And there are certain drugs that can cause stroke. Mostly it is the opioid-based heroin, cocaine, or phencyclidines, amphetamines. All these have a risk of causing strokes in the patients. So that's about. And CNS infections, anyone who is an IV drug abuser, they're at a risk of endocarditis and CNS meningitis. That is something that needs to be kept in mind. So alcohol can lead to arrhythmias. So when differential diagnosis of someone obtundation, which I tell all my trainees to at least go through this mnemonic is AEIOU tips, where you look for alcohol, arrhythmias, epilepsy, electrolytes, infections, overdose or hypoxemia. U stands for uremia, metabolic. T stands for toxin trauma. I is insulin hypoglycemia. P is psychosis. S is stroke. E is endocrine, like myxedema, coma, and so on and so forth. So this is just a differential diagnosis mnemonic for you to remember to run through the list which may be causing obtundation or encephalopathy in patients who come to ICU. So that's about toxidromic categorization of drugs manifesting with neurological symptomology. Then how about ECG based toxidrome classification? So ECG, you have to look at toxins causing bradycardia, toxins causing tachycardia. So if you have a patient with nystagmus with bradycardia, then the possible cause is lithium toxicity. So this is the way we can group this toxicology. And there is only one drug which causes vertical nystagmus, which is a drug of abuse, which is penicillin toxicity. And all the types of block, first degree AV block, second degree AV block, Mobitz 1 and 2, and type 3 heart blocks, all these can be caused by all the antihypertensives like beta blockers, calcium channel blockers, and digoxin. So toxicology, any toxicity with any of these drugs, penicillin, lithium, beta blockers, calcium channel, can lead to various types of heart blocks and bradycardia. And opioids can cause prolonged QT and bradycardia. And cholinergic drugs like OP compound poisoning, we know it can typically cause bradycardia. And tricyclic antidepressants, class 1AC antiarrhythmics like quinidine, procainamide, encanide, flecainide, all these can cause toxicologic bradycardia. So just a tip and a clue. There's a separate video where I've spoken about ECG in toxicology. When you look at the ECG where you're suspecting poisoning, always look for R in V1. Most important, R in ABR. R in ABR should indicate to you that there is some extraneous drug that may be leading to some disturbance in the ECG. So that is a simple clue, which anyway I will show you to in the end, ECG identification. And toxicologic bradycardia, Brugada syndrome, which is a genetic one. So there is type 1 Brugada where you have this sort of a elevation in V1 or you have this saddle pattern in the V1, which is type 2 Brugada. So if someone has a genetic predisposition, if they are on tricyclic antidepressants or class 1A, 1C antiarrhythmics like quinidine, procainamide, encanide, flecainide, it can precipitate Brugada syndrome and they can go into arrhythmias. So that's about toxicologic bradycardia. So let's look into toxicologic tachycardia. Tachycardia, it can be wide QRS or narrow QRS. So if it is wide QRS, toxicologic tachycardia, it can be antidepressants like venlafaxine, bupropion or mirtazapine, or antipsychotics like phenothiazines and carbamazepine. Or it can be class 1A, 1C antiarrhythmics like quinidine. So this quinidine, procainamide class 1A, 1C can cause brady or it can cause tachycardia as well, or antihistamines like diphenhydramine. If it's a narrow QRS, it must be sympathomimetic drugs like adrenaline or anticholinergic drugs like antidepressants, antipsychotics, and antihistamines, or cocaine addicts or opioids. So any of these can cause narrow QRS tachycardia. So that's about ECG-based toxidrome classification. So the first I spoke about toxidromes based on neurological presentation. The second was on ECG. So cardiovascular and neurological we covered. So how do you ascertain prediction of hospitalization using ECG as a base for prognosticating the toxicology? So if you have a patient with suspected acute poisoning, look at ECG and see if they have ectopy or no ectopy. If they have ectopy, then it is an indication that they are at a high risk of acute cardiovascular events, 64% risk of acute cardiovascular events. If there is no ectopy, look for whether they are in sinus rhythm or no sinus rhythm. If they are in sinus rhythm, the first thing you can look at is the two things you need to look when you're suspecting toxicology are in ABR, R in V1, and look for QTC. Look for QTC. QTC is a very sensitive indicator to suggest whether there is any drug causing any risk of potential arrhythmias. If it is normal QTC, very low risk of them developing cardiovascular event, 3.8%. If they have a long QTC, they are at a moderate risk of developing acute cardiovascular event at 26%. If QTC is more than 500, they need to be kept in ICU, observed because they are at a high risk, 38% of acute cardiovascular events. So this is the risk stratification of toxidrome based on ECG. So we finished neurology, we finished ECG based. So now we'll jump into what are the newer therapies which are becoming available for toxicology, which possibly was not available 10 years back, was all extracorporeal therapies. So the new kid on the block, which is saving lives in toxicology, is VA ECMO. So especially in toxins which causes hemodynamic compromise of any nature, like cardiotoxic drugs, it can be calcium. We have treated quite a few of calcium channel blockers, beta blockers, and sometimes we have put them on ECMO. So where ECMO becomes life-saving in these sort of poisons, which causes gross hemodynamic instability. And we have hemodialysis and CRRT and various filters which are helpful in removing the toxins and it may be used in some of these poisonings like valproate, caffeine clearance, where hemodialysis or CRRT can be used to eliminate and remove the toxin. And hemoperfusion has a specific role in certain poisonings, even in paraquat, which is a deadly poison. Even a sip can kill. Early hemoperfusion has shown some promise, or theophylline toxicity, where hemoperfusion is something that can be used. And plasmapheresis can be used for immunotoxins. I'll show you a case where we use plasmapheresis in our patient, which is a unique poison. So one has to keep all these modalities in mind as a newer modalities to save life in poisoning. So I'll take you through select poisons that we have treated with these extracorporeals. So paraquat poisoning. So please be very friends. This is a very deadly herbicidal. One sip can kill the patients. We have seen quite a few of these. So when you look at treatment of paraquat, it is always airway breathing circulation. But the crux of whole paraquat is not to hyperoxygenate them because they develop rapid lung fibrosis and generally death becomes inevitable. Activated charcoal early on at 1 to 2 grams per kg has found to be helpful. So if they are maintaining oxygenation, please don't give oxygen because there's a lot of oxygen free radicals they produce and there is rapid pulmonary fibrosis that they develop. So avoid giving oxygen unnecessarily. Riles tube, you have to be very wary because there's a lot of esophageal ulcerations and oral ulcerations that will be there. So you may have to place it very gently or with a Frica tube. And sucralfate and lignocaine viscous is something we can use. So ventilation, they do get progressively hypoxemia. You may have to support them with non-rebreathing mask or with HFNO, and eventually they may need intubation and mechanical ventilation. When they become ventilated, one has to consider artsnet ventilation and maintaining permissive sort of hypoxemia or maintaining just about enough oxygen at 80 to 90%. And generally, once they go to this stage, they have a stormy course and eventually they die. So the role of hemodialysis and hemoperfusion, eventually all patients with paraquat, they go into liver dysfunction and acute kidney injury. So needing hemodialysis. So hemoperfusion less than 4 hours is shown to be beneficial. So this is one reference study, Denise Oliveira, where they've used hemoperfusion for 7 sessions of 6 to 8 hours within 4 hours. And it was shown to be effective in reducing the serum paraquat levels to less than 0.2 milligram per liter. So what are the newer modalities for prevention of pulmonary fibrosis? So a lot of trials have looked at, not trials, more of case series and few studies have looked at role of methylprednisolone, dexamethasone, and cyclophosphamide as a means to reduce the lung inflammation and reduce the lung fibrosis. So this is one reference study which came from Sri Lanka, where they've used high-dose immunosuppression to prevent death after paraquat self-poisoning. This was a randomized controlled trial, where they compared one group where they used IV cyclophosphamide 1 gram per day for 2 days, plus methylprednisolone 1 gram per day for 3 days, and de-escalated to oral dexa at 8 mg twice a day for 14 days versus placebo. So unfortunately, they did not find any positive results. So they had 299 patients. If you see, there was no difference in hospital mortality between the immunosuppressant group and the placebo group. They looked at 3 months mortality. There was no difference between the placebo group and the immunosuppressant group. And there are a lot of case series claiming some benefit with the use of N-acetylcysteine at this particular dose, 150 mg per kg over 3 hours, followed by 300 mg per kg for 24 hours. And they've used vitamin C, 300 mg TID. They've used chelating agents like desferoxamine, which chelates iron and reduces hydroxy radicals. And they've used salicylic acid as a scavenger for hydroxy radicals. All these are available as case series and anecdotal case reports. No conclusive evidence if all this can save a life. And recent advances, they've used edaravone as a oxygen free radical scavenger and as having anti-apoptotic effect and anti-inflammatory effect. So there is one reference study for use of edaravone in the treatment of paraquat poisoning, where they've used edaravone in 44 patients. And they found edaravone was found to have protective effect on the kidney and on the liver, and it delayed pulmonary fibrosis, but there was no mortality benefit, even with the use of edaravone. So there was no survival benefit. So basically, all the measures used, like hemoperfusion within 4 hours, antioxidants, immunosuppressants, edaravone, none of them have shown survival. So right now, there is no definitive management which can save a life, and ECMO, which is making new waves in sort of organ support and saving lives. So it has been used as a bridge to sequential bilateral lung transplantation. But when you look into the literature review, even the transplanted lungs develop fibrosis, so it is that lethal, and one has to weigh the risk-benefit balance and cost-effectiveness of using such modalities in paraquat poisoning. So that's about paraquat. And what is the new things in calcium channel blocker? So just there is a separate video on that. So what about the role of ECMO in calcium? We have used ECMO in CCB, but before putting someone on ECMO in calcium channel or beta blockers, I just want to sensitize our intensive care friends to max out on the medical therapy available. So when I say max out on medical therapy, because this is just a list to show what all drugs need to be used medically before you embark on putting them on ECMO. So if you look at this particular paper where they have looked at the type of insulin they've used 60 units, 40 units. But let's look into the type of insulin one has to use because this is where you need to max out on medical therapy before you see there is a treatment failure and the risk of them needing ECMO. Because we have had one patient where we used very high dose insulin at a recommended dose of 10 units per kg, and we could wean the vasopressors and get the patient out and not go towards ECMO. But the second, another patient, despite using the maximum insulin, patient had to go to ECMO. So just a flow chart of approach to calcium channel blocker poisoning. Give calcium chloride 10 to 20 ml every 10 to 20 minutes for 3 to 4 doses. Obviously, there'll be hypotensive. You have to start norepinephrine or epinephrine titrated to response. After this, you need to consider glucagon 5 to 10 mg, 1 to 2 minutes, and give it as an infusion at 2 to 10 mg per hour. After that, this is most important. One has to use high dose insulin. When I say high dose, it's 10 units per kg per hour, which means if there is 60 kg individual, you are using up to 400 to 600 units per hour, along with glucose and fat emulsion, 1.5 ml per kg, 20%, followed by 0.25 to 0.5 ml per kg per minute for 30 minutes. So all this we have used in patients who have come to us with CCB overdose. All this fail. You do high dose insulin with dextrose, with glucagon, with fat. Even after that, there is no weaning of vasopressors. There is a worsening of lactate. That is when one may have to consider ECMO as a life saving. And definitely, ECMO will save lives when they come in this stage where your maximal medical therapy has failed. They would benefit from ECMO. So this is the newer advances. So then the third one, I will end with this particular case scenario. So this was an interesting case, a 19-year-old female who came with 10 ml of unknown compound. She was a biotechnology student, and she had visited a dark website, dark sites or dark websites where there are web pages on facilitating the suicide methods. So here she had looked into the dark website and gotten information on suicide kits. And she had consumed, and she came like this. She was fully blue when she came. So, in fact, this picture you can't appreciate. Everything was blue in her. She had only consumed 10 ml compound guided by this dark website. And she came with methemoglobin of 65.5% with lactate of 6.3. And she had consumed sodium nitrite. And this is easily available. This is used as a preservative for various things. And she had brought this based on recommendation from this dark website as a means to commit suicide. So what does this sodium nitrate do? So this sodium nitrate converts ferrous to ferric ions, and this ferric ion has inability to bind to oxygen in the hemoglobin. So the oxygen delivery, because it's unable to bind to oxygen, so you have oxygen delivery which gets affected, and because there is oxygen delivery which gets affected, tissue hypoxemia happens, increased lactate, and metabolic acidosis sets in. So this is the way sodium nitrate acts, because it very competitively converts into ferric. Because ideally ferrous has a good affinity to oxygen, ferric cannot combine with oxygen, so there's no oxygen delivery happens. So this patient, we had to subject her to plex plasma exchange, and this is the plasma, discarded plasma that you could see. It is actually, it was blue or dirty chocolate color and blue color in nature. So after plasma exchange, the methemoglobinemia level came down. So the normal methemoglobinemia should be negative, or it should be 1 to 2% is acceptable. For this patient, it was around 65%, isn't it? It was 65.5%. She falls in this category. So at 60%, they become lethargy, convulsions, and coma. More than 70%, it is lethal. It can kill. So she was in a life-threatening situation. So the treatment for this sodium nitrate is methylene blue. So we gave methylene blue, which is easily available at 1 mg per kg for 5 minutes. And then after 1 hour, we gave a repeat one at 2 mg per kg along with vitamin C. And then we had to subject her for plasma exchange to eliminate this sodium nitrate effect. So we did plasma exchange plex for 2 to 3 sessions. After this, we subjected to hyperbaric oxygen at 2 atmospheric absolute for 90 minutes. After this, her methemoglobinemia level from 65% came down to 0.6% and she was discharged home. So these three cases which I highlighted, friends, is only to elucidate the newer techniques, especially for paraquat. Unfortunately, there is no modality at this point of time. ECMO can save, but obviously they have to go for lung transplant because it's not a bridge. The bridge, it can only be used as a bridge if you are contemplating lung transplant. Calcium channel blockers, the only message is max out on medical therapy before you embark on ECMO as a life-saving measure. And then you have this new bizarre poisonings and with the dark websites promoting easier way of committing suicide in various ways. Be aware of these sort of exotic chemicals which are being utilized and the type of modalities like plasma exchange was valuable in this and hyperbaric oxygen was valuable along with methylene blue. So lipid emulsion therapy is a new sort of a concept, which and this is re-emphasizing the lipid therapy in calcium channel blocker. It is a way to create a lipid sink. So basically, in the plasma, you create a lipid sort of a enriched sink, which facilitates absorption of these verapamil or calcium channel blockers or diltiazem or tricyclic antidepressants. Basically, it enhances by doing this, it promotes myocardial contractility by preventing the conversion of free fatty acids to carbohydrates and improving the myocardial contractility. And the dosage, as I mentioned in CCB, is 1.5 ml per kg or 20%, and then as a at a 0.25 to zero point 0.5 ml per kg for 30 minutes. So we use this in calcium channel. It's easily available. We can all use it. When there are lipid infusions, one has to monitor triglyceride level. Efficacy is come from case reports and case series that I just showed. So last slide. So what is the future of toxicology? Future is we possibly need AI predictive models on ascertaining the severity of toxicity when they come with different toxins. So AI possibly has a role in predicting the trajectory after the toxicity and nanotechnology for effective delivery of the antidotes in a precision way to circumvent and mitigate the toxicity. Precision medicine has a way to go, and having this tele ICU and the digital health in an integrated network to facilitate effective optimization of the toxicology cases in our country goes a long way in saving more lives. And we need a large registry based outcome database for different toxins for us to have some sort of a semblance as to the effective means of therapeutic sort of modalities that are available. And we need bioengineering advances to enhance the extracorporeal devices, to have more newer extracorporeal devices which can eliminate various toxins in these sort of overdoses and accelerated antidote development. So these are some of the elements that we have to focus on as to the future of toxicology. So that's about it, friends. So I request you all to submit your valuable work to Journal of Acute Care. You can, of course, visit my website to read to this lecture. Thank you. So I just focused on toxidrome classification and some of the newer exotic toxins and the newer modalities. Thank you. Thank you, Manato.